bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, the McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, and the Holland Bloorview Children's Rehabilitation Hospital Foundation. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAFC's programs and activities.
Hello everyone, and welcome to today's episode of CAFC Presents. My name is Doug Maynard, and I'm the Associate Director at CAFC, the Canadian Association of Pediatric Health Centres. Today's webinar is titled Building Bridges, Moving Research to Practice, and we're going to be talking about all things related to making things happen with evidence and getting them to the bedside, bench to the bedside, and all those other slogans that we like to use to try and make things happen in our organizations. So today's topic has come to us actually from our rehab network within CAFC, the Canadian Network of Child and Youth Rehab, or CINSER, and it's my pleasure to have the co-chair of CINSER's KT and Research Committee, Dr. Gail Andrew, who joins us from the Glenrose Rehabilitation Hospital, along with all of our other presenters that I'll introduce in just a minute. But Dr. Andrews here to help me co-host this session, so I'm just going to hand the virtual podium over to Dr. Andrew just for a few words to kick the session off. Over to you, Dr. Andrew.
Thanks, Doug. CINSER has, one of our goals is to improve the care and outcomes of children and youth and their families who have rehabilitation needs. And we define our population quite broadly, neuromotor populations such as cerebral palsy, spina bifida, and into the behavioral developmental disability groups such as autism, fetal alcohol spectrum disorder, learning disabilities, and so on. One of our core activities is really to strengthen that bidirectional flow of information between clinicians and researchers. We know that clinicians in rehabilitation can identify areas of need and help define the research questions, and also really have the first-hand, on-the-ground knowledge about where areas for quality improvement need to be focused. And researchers, we depend on them to bring that evidence to inform changes in practice. This conversation is good, but how do we actually make change in practice if that whole thing revolves around implementing the knowledge and getting it into the groundwork? So we need to have that mechanism for implementation and acknowledging that there's going to be challenges, whether it's funding challenges, need for a cultural shift, staff expertise, training, and fidelity to the change in practice. We also need strong evaluation, both from does that change improve the quality of care for the child and family? Are their outcomes improved? And are we really using best resources, both of not just the dollar resources, but the best use of people resources? And this speaks to the need for implementation science. And I'm very pleased to have presenting with us today two of our experts from the Glenrose Rehabilitation Hospital, where we do have a team of people who are helping work on all these points that I just mentioned. So it's been great to take the vision of CINSER and see where we can go with this new information today. So I'll turn it over to you, Doug, to introduce our two speakers.
Thanks, Gail. So I'm just going to introduce our panel, who are also in the room with Gail at the Glenrose Rehabilitation Hospital in Edmonton. So we have on our panel today, and I forgot to mention at the beginning, this is actually part one of two. So this week and next week, we'll be doing the Building Bridges topic on implementation science. So for today's episode, we have Cindy Koning from the Glenrose Rehab Hospital, and she divides her time between roles as the Knowledge Mobilization Specialist for the Canadian Spinal Cord Injury Knowledge Mobilization Network, that's a mouthful, and the Glenrose Rehab Hospital's Healthcare Improvement Team. She has her PhD in rehab medicine from the University of Alberta and has a long history as an occupational therapist working in the field of occupational therapy and adolescent psychiatry and assessment diagnostic clinics and developmental pediatrics. And we also have Laura Mummy from also from the Glenrose, and she's the Knowledge Mobilization Consultant at the Glenrose Rehab Hospital in Edmonton. She's a member of the Glenrose Healthcare Improvement Team, which supports the evidence-based clinical practice across the site through an integrated approach to research, outcomes evaluations, knowledge mobilization, and quality improvement. So it's my pleasure to hand the podium over to our presenters from the Glenrose. Over to you, Cindy and Laura.
Thanks, Doug. Actually, it's Leslie Weir speaking, so I'm also going to join in on the presentation today with Laura. And you'll have to wait another week to hear from Cindy. So next week, Laura and Cindy will talk specifically about an example of knowledge mobilization at the Glenrose regarding autism diagnosis. But today, Laura and I are going to talk more generally about evidence-based practice and about the knowledge mobilization framework that we've adopted at the Glenrose. So welcome everyone, and we'd like to thank CAPC and CINSER for the opportunity to present on some of the work that's being done at the Glenrose in relation to translating research knowledge into practice. So we're a newly developed team, and so we're still in the process of developing some of our structures around our team, but we hope to share with you some of the work that we've done so far. So today we'd like to talk about current issues in evidence-based practice to provide the context as to why we need more systematic processes, as Dr. Andrew mentioned, for implementation of changes in service delivery or clinical practice. And then Laura is going to talk more specifically about an approach to implementation that's developed by the National Implementation Research Network that we've adopted at the Glenrose. As you all know, we've known for some time that we have challenges with translating research evidence into clinical practice in healthcare. So researchers have evaluated the time lag between research to support effectiveness and uptake in practice. In the systematic review that I've mentioned here, the authors identified 23 articles that evaluated the time lag and found the average time to implementation to be 17 years, which I think we would all agree is a long time. So not only do we have challenges with the amount of time it takes to change practice, but we also see inconsistencies when we think about how evidence is translated into practice. So I'm sure we can all think of instances in our center in which we see variations in clinical practice. So of course, some variations in clinical practice are acceptable and some variations in clinical practice are not. So there have been many studies to demonstrate that unacceptable variation in practice exists across different clinical contexts. And common examples would be the overprescription of antibiotics for upper respiratory tract infections, and in the adult world, thinking about variations in the treatment of chronic heart failure. There's many other examples in the literature. So this knowledge to practice gap has, I'm sure you all know, has inspired our focus on knowledge translation. And this is the CIHR definition of knowledge translation. It's a dynamic and iterative process that includes the synthesis, dissemination, exchange, and ethically sound application of knowledge to improve health, provide more effective health services, and products to strengthen the healthcare system. So today we're going to talk more specifically about knowledge mobilization, which is actually embedded in this definition. So knowledge translation would encompass a variety of strategies, including the traditional, more passive strategies, but knowledge mobilization is more focused on the active process of putting knowledge into action. So as I mentioned earlier, Laura is going to talk about a specific process later on in the presentation. Of course, one of the major advances in bridging the research to practice gap was the development of the evidence-based medicine or evidence-based practice paradigm. The steps of evidence-based practice are outlined in a series of articles focused in the journal, the American Medical Association journal, JAMA, and compiled as a book called The User's Guides to the Medical Literature. I'm sure most of you are familiar with this approach that was developed by Dr. David Sackett and colleagues at McMaster University. So the goal of evidence-based practice is to ensure that best treatment decisions are made for individual patients based on patient values and expectations, the best available evidence, and expertise of individual clinicians. So here are the steps of evidence-based practice. They are designed to assist the individual clinician with defining a clear and focused clinical question, with finding evidence appropriate to the question in consideration of different study designs and the most appropriate types of evidence, so whether that be individual studies or systematic reviews or meta-analyses, synthesized data sources if they're available, or knowledge products such as clinical practice guidelines. The next step would involve the appraisal of validity of the evidence and consideration of the magnitude of any effects. And finally, the apply stage is the application of that research to practice. So ensuring that clinicians have an understanding of how to critically appraise evidence is a crucial component of evidence-based practice. So this model really does focus on this, but it doesn't really focus or provide any specific strategies for processes for actually implementing practice change. So over the past 10 years or so, there have been several changes that have influenced how we think about evidence-based practice. So firstly, our evidence base has now evolved considerably in pediatrics, and we now have a proliferation of individual studies, synthesized sources of evidence such as systematic reviews and meta-analyses, clinical practice guidelines, and various different resources at point of care. So for example, yesterday I conducted a simple search using the search terms child and randomized controlled trial, and I limited the results to individual articles. So there were 13,000 articles between 1994 and 2004, and double that, so over 26,000 articles from 2004 to 2014. Many organizations and groups of researchers have developed evidence-based clinical practice guidelines, and I'm sure you've seen there's been many developed in the past few years. So for example, European Academy of Childhood Disability, American Academy of Pediatrics, and so on, and I'm sure you're aware of other organizations and groups of researchers who have developed clinical practice guidelines. So another advance is that several studies have explored the factors that are reported as facilitators and barriers to successful implementation of evidence. So initially, I think we did focus on individual clinician factors such as attitude, knowledge, skills, habits, and personality. But I think now we have a much greater awareness of the social and organizational factors that affect translation of evidence into practice. So social factors include expectations of patients, colleagues, authorities, various authorities, whether that be actual or perceived. And organizational factors include the specific resources, organizational culture, and structures and care processes within individual organizations. Although more research is definitely needed, we are also now more aware about the strategies that do and don't work for changing practice based on research evidence. So diffusion refers to the more passive approach, that is, those are the traditional methods that were used by researchers, sometimes called the storefront model. For example, publication in journals or presentation at conferences. Dissemination strategies are still more focused on sharing information, although the message is much more tailored to individual audiences. And active implementation refers to more active, planned, and systematic processes for practice change. So although I think all of these processes are important for sharing information about research findings, we know that the active strategies are more effective for actually changing practice. And also there's some evidence that multiple strategies are also more effective than single strategies used alone. So the approach that Laura is going to talk to you about today is an example of active implementation. So it's clear that we need to improve our ability to efficiently integrate evidence into practice, and there are potential benefits to the implementation of valid evidence. Potential benefits include reduction in inappropriate care, and of course, conversely, increase in appropriate care, increased efficiency as we're able to focus on the most effective interventions, and of course the most important potential benefit, which is improved patient outcomes. I think few would argue that we need to figure out better ways or improved ways to use evidence to inform practice, but why can't we just do it? And I think partially because we don't have systematic processes that support implementation often. Until fairly recently, we have placed the focus on obtaining and appraising evidence, which is of course important in the process, but I think just not sufficient. So we haven't made the processes involved in implementation explicit. Now we're starting to pay more attention to the steps that happen after we have valid evidence that we would like to use in practice. This is the well-known knowledge to action cycle that was published in 2006 by Ian Graham and colleagues. It encompasses both the creation of knowledge, as you can see in the center, and the knowledge use that's represented around the periphery. The upside-down triangle represents the funneling of evidence from individual research studies at the top to more synthesized forms of evidence, such as meta-analyses and systematic reviews, to knowledge products, such as clinical practice guidelines or practice parameters. So once you've identified your problem and then selected the evidence that you would like to use to inform your practice, you decide how to adapt your knowledge to the local context. So I'm moving around the circle now. Of course, some changes will require few adaptations to local context, and others will require more significant changes. You can then determine how to address any barriers to knowledge use, implement those changes, monitor use, and evaluate outcomes. So we tend to focus on the evaluation of outcomes, but I think this model reminds us that it's also really important when we're changing practice to also evaluate change in process so that we can really determine to what extent the intervention is being used. So this is the fidelity piece. Laura will talk about this in more detail when she talks about the National Implementation Research Framework. I think it's also important to acknowledge that change is just inherently hard. Without providing support for practice change, it's likely that implementation of change will be variable. This was a very interesting article that I found published a while ago in 2005 called The Translation of Research into Practice, Why Can't We Just Do It? So the authors examined cognitive processes that are involved in expert learning and applied that knowledge to evidence-based practice. So expert learning is typically conceptualized as moving through awareness to acceptance to adoption. Most of our activities, when you think of our traditional activities for knowledge translation, such as continuing education courses, providing information and education on clinical practice guidelines, for example, really focus on the first two stages of awareness and acceptance. And as I mentioned earlier, we typically spend or focus less on the processes that are needed to facilitate adoption. So the challenges arise when knowledge of evidence suggests practice change that is different from well-rehearsed practices that have become automatic with clinicians, and particularly when you think about expert clinicians, where a lot of their practices are become somewhat automatic and embedded in their repertoire. And that is because when we learn a new skill, we go through different stages of learning. So initially, when we're at the declarative stage, we're really working on constructing a memory of the new information that we're learning. So there is research to support the benefits of our traditional approaches, like continuing education courses, that those kinds of activities do have a positive impact on declarative knowledge. So I think that's really an important point when we think about effectiveness of these strategies in terms of changing practice, because they are important in terms of the learning stage, but they're just not sufficient in order to ensure that we change practice. The next stage is the procedural stage that involves more integration of that knowledge. So working through different scenarios to develop relationship between new rules of practice, so that would be developing if-then scenarios. And so not surprisingly, practice change is likely to be more successful if the context of clinical practice is similar to the context of the evidence, because the transition to the new if-then strategies is much easier for the clinician. The autonomous stage represents the stage where skills become much more automatic. This is where there's more fine-tuning and performance, but the majority of learning has already taken place, and this would be at the expert clinician level. And I see this as sort of similar to when I find myself at work and I actually don't remember actually the drive to work. So that skill has become very automatic for me. So what's interesting is learning at these stages involves different structures of the brain. So as new memories are formed in the hippocampus, and as with experience, information is distributed to the cortex. So it really does, when you think about clinicians that have developed over years expertise that have reached that expert clinician stage, it really takes a concerted effort to go back to that declarative stage and work through the processes again to implement a new behavior. So I think in summary for my section, change is complex, both at the individual level and when we think about complexity of our service delivery systems. So there's many different moving parts that need to move synchronously to achieve the outcomes that we want to achieve. And so it's clear that we need to find ways to support clinicians in practice change that are planned and systematic, and that's what Laura is going to talk to you about now.
Thanks, Leslie. Hi, everyone. I think Leslie has just done a really great job of kind of setting the stage for that there is a gap that exists in our from research to practice, and that one of the approaches that the Glenroe has taken is to adopt the National Implementation Research Network's active implementation frameworks and use implementation science to really focus on our process of implementation and not just what we're implementing, but how we're doing it. So just a little bit of a background. The National Implementation Research Network is actually a group out of the University of North Carolina who did a synthesis of literature over about 30-plus years and looked at a bunch of organizations internationally that had successful organizational change. So it wasn't exclusive to healthcare. It encompassed, I think, things like education, emergency preparedness, healthcare. There's a couple others as well. And so they really looked for themes at what was successful change, what actually facilitated that successful change, and then they flipped it into a framework. So lots of this stuff that you'll be hearing today probably isn't new information. It's just how it's been packaged in a more systematic way so that we can really have an approach to implementation and really be guided by these steps as well as some supporting tools that NERN has developed. So this is something that we all, I don't think, will disagree on, that our patients really can't benefit from any interventions that they're not experiencing. So what our goal is to always provide them with the best care and the latest evidence of care so that we receive the best outcomes. I think the fiction part, though, that exists is that just because we have strong research evidence for something that demonstrates good outcomes, doesn't mean we're going to see that in practice unless we really take a thoughtful, more purposeful approach to the implementation and integration of that practice, so that we really are focusing on not only what we're implementing, but like I said, the process on how we're doing it to really achieve what we want to achieve. So both are equally as important. So once again, here's a little visual on how we have research way over on the left-hand side and practice way over on the right-hand side. And what we're really trying to do is join that gap. And once again, I said that the Glenroe has taken this implementation science approach. This isn't the only approach. There are other frameworks that exist, but this is the one that we've really chosen to adopt and try to spread and apply in multiple different settings across the hospital. So what really is implementation? And it really comes down to a purposeful set of activities that is really related to that program or intervention or practice that you're trying to implement. And it's a more systematic and thoughtful approach to bridge that gap. So ultimately, our patients and families can benefit. So this applies to a number of different groups and a number of different patient populations. Like I said before, this is a process that is not really doesn't really discriminate on what you're implementing. It's a process on how. So we've applied it with multiple different disciplines and multiple different teams who are, currently treating multiple patient populations. And it can be done at multiple levels. So when I'm saying that, it could be applied to a specific nursing unit or a specific occupational therapy program, or you can look at it at larger change levels, for example, a site initiative or something larger on an organizational level. So it really doesn't discriminate. It's just a process on how to help facilitate change. So simply put, we really just need to know a few basic things that obviously come with complex activities, but ultimately what we need to know is what we're implementing, so what's our intervention or our evidence-based practice or even because there's lots of new emerging technology, what are we really trying to implement? Also, how are we going to do that? How are we going to make it effective and sustainable, and really think about what we want to achieve at the end of the day? What are those steps that are going to get us there? And finally, who's going to be involved? So not just who your intervention is applicable to, what patient population it's applicable to, but also who's really identified in doing and supporting this work. So this is all these three pieces are really about making it happen, and that's what we want to achieve. So I'm just going to briefly list off. There's 5 active implementation frameworks that the National Implementation Research Network has developed. One is implementation teams, usable interventions, stages of implementation, implementation drivers, and improvement cycles. And one of the challenges that we've had after applying this multiple times on the site is really figuring out how to integrate these the best as possible. So in order to make it nice and clear today and hopefully as practical as possible, I'm going to focus on the stages of implementation and going through those 4 stages and really highlighting some key activities to complete in each stage to really help build sustainability and effective process implementation to support your practice that you're trying to implement. So I'm really going to focus on those key activities and try to make it, like I said, as practical as possible. So here are the stages of implementation. One thing you'll notice is that even though it's in a linear diagram, it's not a linear process. So you have overlap within each stage, and also there's arrows going in both directions, because this is a process in which you may have to go forward or go backward to stages depending on where you are and what challenges you're seeing in your implementation process of your practice. So you can move between each of the stages. And one of the key things to remember that NERN is really trying to reinforce is that we're building sustainability at each of these stages as well. We're not just waiting till the end to make up a plan on how this will be sustainable. We're really trying to integrate key activities to support the change on a long-term basis. Now, this may be a scary number of 2 to 4 years that implementation takes to achieve, but that doesn't mean that it's 2 to 4 years before anything happens. It means it takes 2 to 4 years to be fully implemented, where the practice is working well, and that you're seeing the outcomes that you intended to see. So what I'll do is I'll go through each stage, and I'll be able to highlight some key activities in each stage to achieve. So let's start with exploration. So simply put, you need to decide on what you're implementing as a team. So to help facilitate that and to really think about, well, what we want to implement, it's first really important to establish an implementation team. And traditionally, I think we've put together committees to help facilitate some of these changes, and NERN uses this word implementation teams that's more active. So I'll highlight that. There's also, it's important in exploration to really define what you're implementing, and as a team get a common understanding of what you're trying to achieve at the end of the day, so you're all on the same page. It's also important to assess your implementation environment and understand where the barriers and the challenges lie with implementation within your program or unit or site or organization. So you really understand what type of environment you're trying to integrate new systems or improving existing systems in. Identifying expertise and resources is also important because you may want to pull in on that to help facilitate your change. And finally, it's important within this stage to really start thinking about the outcomes and the measures and the indicators that are going to tell you how your implementation is going. So not just your clinical outcomes, but also thinking about your process and how you're doing in your process to see if your plan is working to meet the outcomes you want to see. So what I'll do right now is I won't go into detail of all of these, but I'll want to talk a little bit about implementation teams and who they are and what their primary functions are. So really, this team are the people doing the work. And Leslie alluded to earlier that there's methods to moving knowledge, and the implementation team are the people who are going to be moving that knowledge. And what we kind of know is that diffusion alone is not going to support the change. We also know that dissemination alone is helping that happen, like Leslie said earlier, tailoring that communication to a specific audience, but it's really not causing a behavior change in practice. So what this team's focus is really active. It's making it happen, it's supporting the change, and it's really being accountable for the work from beginning, middle to end. And really it's about this team just getting started and improving their processes and their plan and making it better so that you're seeing the outcomes you want to see and you're seeing the practice that you're implementing to be used as intended. So implementation teams generally are moving through this process of assessing, planning, executing a plan, and then monitoring and supporting those changes throughout all 4 stages of implementation. So even though I'm talking about creation of the implementation team in the exploration stage, they exist throughout all 4 stages and at a high level have these 4 functions. But the main role that I want to take home with everyone is that they're accountable for the work and that they're really the ones that are supporting the change. So here's a list of some key functions for an implementation team, and I'm sure everyone can pull on past experiences or knowledge on how to build effective teams. But really, once again, from an implementation perspective, we really want this group of people to not only represent currently what is happening in your system or your area, so the current knowledge and expertise that can provide that that culture and that context to the environment, but also a group of people that want to see change and want to represent the system to be. So once the change is implemented, how is that looking and how is that being supported? So we want the team members to really represent both of these. A few points that I want to highlight is that implementation teams are really ensuring that the practice or program or intervention is being implemented with fidelity. That is being implemented and used the way it was intended and the way that the team is defining it. And also that the team, in order to continually improve how that practice is being implemented and continue to learn how things are or are not working, is they're using data and feedback and the information from their evaluation to really inform purposeful decision making. So some of our teams at the Glenrose have been very successful when there's been a strong leadership presence on the team, and it's really helped our team overcome challenges. So when you're thinking about building a team, I would say that one strong component is to ensure that there's someone who has decision-making power that can sit on your team, that's engaged in the work, and that can help you through some of these challenges. Also, something to consider is who at the implementation level might be impacted by some of these practice changes, and can we engage some of those people to sit on this team, whether that's representation from multiple disciplines or multiple perspectives in that practice, so that we can really add value and include them in the decision-making process so that we're not missing any pieces. So just a little piece of information that at the Glenrose, when we first started applying this framework in 2010, we had one implementation team. And now we have grown since to 16 and growing implementation teams. So this will just give you an idea of how we've really spread this concept of implementation science and building effective implementation teams. And these teams exist across multiple divisions in our hospital, so not just in pediatrics, but also in adults and geriatrics. So who knows how big it will get. So another point I wanted to highlight in the exploration stage is to focus on this common understanding and agreement about what is being implemented. I think so often our teams know what we want, but we're not clearly defining what that means to all of the team members on the implementation team. So when you get further into the process, we kind of question, well, I thought we were doing it this way, or I thought that's what that meant. So I'm going to talk a little bit about developing that common understanding. So we really want to define what we're implementing. And what we're implementing is what Nern likes to call a usable intervention, which is really a program, practice, or intervention that is teachable, which means that it can be trained, so you can build in a training component, that's learnable, so that it can be supported through coaching and mentorship, that is doable, so that can be applied so that you can see a behavior change, and that also that can be assessed in practice. So really that can be measured on how accurately the clinicians are doing the practice, so that fidelity piece. So what are we trying to measure at the end of the day? What outcomes do we want to see? So for some of these practices we've used, for some of this, we've used this approach when we've standardized our ASD diagnosis best practice statements and clinical guidelines. So in that project, we'll talk a little bit about how we did that in webinar 2. We've also used this approach of defining what we want to implement in terms of pressure ulcer prevention in spinal cord injury patients, and also in the standardization of lower leg assessments in geriatrics. So it's really, like I said, it's applicable to any practice that you're trying to implement. Those are just a few examples of how we've applied this at the Glenrose. So these are the 4 features that I'm going to go through that your team, your implementation team, should have a discussion around and really clearly define in terms of the practice that you're implementing. So first of all, your intervention or your practice or your program needs to have a clear description. So if the practice or program does not clearly come with a description from the literature, which is often, then your team needs to clearly define and describe it. And it's important to define and describe it within your context. So even if the practice may come with a clear description, it may not be 100% applicable within your context, and you may have to adapt that. So ensuring you start with a clear description is important. It's also important to establish what are the clear essential functions that define that practice or program. So think of these as components of the practice that are critical to its proper function that should be implemented. And it's important to define these so you really know what to measure. So these are things that could be critical to the practice, that if they didn't exist, the practice wouldn't exist properly. So think about those, and then also think about how we could measure those. The third feature is around operational definitions of those essential functions. So once you've clearly identified what those essential functions are, it's now important to define them within your context once again. So what does this practice actually look like? What do those essential functions look like within your setting, within your area, or your clinic, or your unit? And what would it look like if you were actually doing it on the ground running day to day? Finally, the last feature to discuss with your implementation team and to be able to clearly define is your performance assessment. So how will you know if you are delivering the practice correctly and the way it was intended? What types of measures should you be putting in place to help give you that information on how everything is going? So it's really important to consider all of these features when you're implementing your practice or your intervention. And if it doesn't have all these criteria, like I said, if it doesn't come in a nice package, then you as an implementation team need to carve out that time to have those discussions so that at the end of the day, everyone's on the same page and has that common understanding of what is being implemented and what that looks like. So I just here put a chart of some other key activities within the exploration stage that really address some of these points on the left-hand side. So supportive teams and structures, we already kind of went through the development of an implementation team of some of those key functions. What to implement, so this is about assessing your environment. This is about defining that practice or program. And it's not an exclusive list of activities in the exploration stage, but it's key activities to get you going and get started. And you can pull in other activities to help you achieve some of these things in order to help move you from the exploration stage of figuring out what fits best for you to implement into the next stage, which is the installation stage. So once you've figured out what to implement, it's really important to figure out, well, how is that going to happen? What's our plan to make this work? What are the changes that are going to help facilitate the adoption of this practice? And what changes do we have to make? And what things are existing in order to help support these? So like I said, you want to figure out how you're going to support what you're implementing and make a plan. So think of this as a planning stage. So once again, here's a list of things to achieve within your implementation stage. And one of the key ones I'm going to focus on is the concept of implementation drivers. So really assessing what's required to support your implementation. Also within this planning stage is it's important to start engaging and communicating with your implementers of the practice. So those are the people using the practice. Some people use the term also first adopters. So ensuring that you have strong communication with those individuals and ensuring that they're ready to support the change. Making the changes and making the plan to make the changes, so to facilitate those changes to support the practice. And not just communication with your first implementers, but also at multiple different levels that could be impacted. So who really needs to know about this change? What do they need to know, and how are you going to communicate that to them in order to support the change moving forward? And this would be an example of communicating with appropriate leadership or appropriate other groups or stakeholders that could be impacted by the change. And finally, within your plan, you have to build in your evaluation planning. Often we tend to leave the evaluation to the end, and it's really important to ensure that you have a clear, that you establish clear objectives and measures on how you're going to be achieving and how to tell if you're achieving those objectives in terms of the process, your clinical outcomes, and also your clinician outcomes on how they're adopting the practice. So let's talk about this notion of implementation drivers, which once again you have probably heard all before. This is just packaged in a different way and in a more systematic way. So what are they? So there's 8 areas that NERN talks about to really discuss with your implementation team and to assess with your implementation team that can help support the practice change. And these 8 areas are usually discussed as your implementation team, but we're going to chunk them up into 3 categories just to make sense of why you're talking about them. So 3 drivers exist within the clinical competency and confidence section. And this is all the areas that are going to support your clinician competency and confidence in delivering and supporting the practice. Then there's a group of 3 drivers that are going to support, from an organizational perspective, the sustainability of the practice. So you're looking at it from not a clinician perspective, but more a system perspective. So what are the areas that are going to support from a systems perspective on how to support your implementation? And finally, the last one's around leadership. And I mentioned this earlier with implementation teams. It's really important that leadership is involved in order to drive some of those changes or to support some of those changes and challenges that you may encounter as an implementation team. So here's a fancy diagram illustrating the implementation drivers. And on the left-hand side, you have the competency drivers that I talked about. So this is selection, training, and coaching. And these are all the areas in which your team needs to have a discussion around and think about maybe building a plan in order to support your clinicians and practitioners delivering the practice. On the right-hand side, we're talking about these system pieces. So decision support data systems, facilitative administration, and systems intervention. And that language is not super clear, but I'll go into what each of those are. And finally, at the bottom of the triangle, we have leadership. So like I said, leadership needs to be involved in order to support those challenges, whether they're really complex or whether they're more simple, in order to support your practice change. And all of this really feeds up into your performance assessment at the top there. So really, how is everything going? Is the practice being delivered the way it is intended? What can you measure to inform if your plan is going to plan? And what changes do you really need to make in order to get the outcomes that you want to see? So one thing to note in here is that this is an interactive, all these drivers are actually interactive, and they're integrated to maximize their influence on behavior and organizational change. So they compensate for one another as well. So if you are weak in one area, in one part of the triangle, it could be overcome by being strong in another. And so that's how they're all integrated. So let's start with our competency drivers and everything that really goes into supporting our staff and our clinicians with this practice change. So like I said, it's all about improving and sustaining the confidence and the competence of our clinicians. So as an implementation team, it's really important systematically to go through each of these drivers and ask some key questions, potentially some key questions for you to discuss and consider. And like I said before, you may be weak in one of these areas, or one of these areas may not even be relevant to you. It may be out of your control, and that's okay. It's just important as a team to really go through each of these and consider them and where you might have to do some work. So some key questions to ask yourself in selection, which is really thinking about who is delivering the practice and what is required of those individuals in order to deliver that practice. So potentially those knowledge and skills and abilities. If you had to choose who those people are, if you had the control to choose who those people are, how could you help reinforce that? So from maybe a manager's or a hiring perspective, what type of questions would you might want to include in your interview in order to ensure that you're selecting the right person to support this practice? And if you don't have control in the selection, which many of our teams here at the Glenrose don't, then what type of role expectations are you going to set for the first implementers, the implementers delivering the practice, those clinicians? Next, it's important for your team to consider, okay, we know who we want to deliver the practice. Now, what is it going to take for them to do that? What type of training requirements are needed in order to get their knowledge, skills, and abilities to a level in which the practice will be properly delivered? So thinking about, do we need to do any training around that? Do we need to do any refresher training around that? What type of materials may need to be developed in order to deliver the training? How will the training be delivered? Is it an in-service? Is it annually? Is it perhaps small groups or workshops? Is it one-on-one? So really thinking about all the training that needs to go in to supporting the practice and supporting the skills or teaching the skills on how to deliver the practice the way it's intended, whether it's a large or small change. Now, even though this is a driver that has its own separate piece, coaching, I really want everyone to think about training and coaching going hand in hand, because you can't train without a support afterwards in order to really get a good behavior change or practice change. So think of them as connected drivers. So once those new skills are taught to our clinicians, it's important then for us to build in a system of support, whether that's through coaching or mentorship, so that we can continue to reinforce and develop and refine those skills that we taught. So things to ask as a team is, who will your coaches be? What type of coaching system do you want to establish? Is it more informal? Is it formal? Is it mandatory? Is it volunteer? And how are you really going to know if that coaching is working for your staff? So what type of things could you measure to help tell you if your training and your coaching are working for your clinicians? And the fourth driver is around this fidelity piece. and really figuring out if we're delivering the practice as intended. And how are we going to know that? And it's really important to think about what we could measure to ensure, for example, if we're being effective in our training. So we have at times built in a survey to our clinicians after a training session to see if their needs were met. That could be helpful to inform whether we want to make any changes to our training program or our materials in order to help further support them. So just thinking about how are we going to know if the practice is working or not. So back to our little diagram, I covered everything on the left-hand side that support our staff. It's also now we're going to talk about more of those system supports that are going to help facilitate the implementation of the practice. So this is all about, like I said, your system and environment, and ultimately you want to figure out how to sustain the practice. So decision support data systems. Once again, not the easiest term to remember, but just think about this as how you're going to use the information you collect. So from your evaluation plan and from your measures, what information are you going to use, who needs to know about it, and how is it going to inform your decision making? So some of the questions to ask as your implementation with your implementation team is once you've gathered all that data, whether that's through qualitative or quantitative data and feedback, what are you going to do with it? So how often will you might review the data? Who will collect and report it? Most of the time our implementation teams are the primary person to take a look at that data because they're ultimately the body that's going to be recommending changes to the process in order to help improve the uptake of the practice. So another driver that your implementation team can consider in terms of your system and your environment is what type of, at an administrative level, what's going to help you move this forward? So what type of barriers or burdens could be reduced through administrative support? And for here, I'm going to use the example of a manager and what they could do in order to support this work. So could you anticipate any of those barriers that are going to occur? And could you engage your administrative supports earlier in order to help address that barrier? Also something to consider is whether your standards or guidelines or policies or procedures are aligning with the new way of work. So if you need to make revisions to those existing documents or you perhaps need to create a document, it's important to consider if you need to do that and whether that's going to be an additional administrative support to the practice on an ongoing basis. Another area to look at is called systems intervention. And think about this more as the culture and the challenges in multiple different levels of systems. So implementing your practice may only affect your small team, and that's fine. So can you really think about what's your culture of implementation within that smaller program or clinic, and what type of barriers or challenge you can see to making change in there? Will there even be a cultural change, or is your team just love change and really adopt change well and really are strong champions of change? Or if there are challenges, can you predict those within your unit or clinic, or potentially other barriers or challenges that may come up from your implementation? So for an example, a change you may make on your unit could also be applicable to another unit, and that other unit doesn't want to undergo a change. So if the thought was to spread that change to another unit, you may have different types of challenges and barriers based on how they work as a team compared to how you work as a team. So it's important to consider those and identify if any of those exist so that you know that you could put some work in to help reduce those barriers. So finally, we'll talk about leadership, which I mentioned earlier has been a really key, not only team member, but also driver to the success of our changes on all our implementation teams here at the Glenmos. So if you have the opportunity to engage a specific leader, what type of qualities would that leader have in order to help support your practice change? If you don't have that choice, then what can you predict on how you want that leadership to be involved, and what type of situations their input and their guidance would be the most effective, and also how do you want to engage them. One of the challenges that we've had is due to their very busy schedules, they can't attend every implementation team meeting, and so we have ensured that we make sure there's strong communication between us as an implementation team with that decision maker so that they're informed about how we're doing and what we're doing, and we're asking for their involvement at specific times, at key times, in order to help move some of this work forward. So it's really just thinking about how you want your leadership to be involved, and I highly suggest that you engage a leader early on in this work. So once again, for your information, I have put together a list of some of the key activities that can be achieved and addressed and completed with your implementation team during this planning or installation stage. And I mainly focus on the 8 implementation drivers, mainly because these are the areas that are also going to help inform your action plan, that are also going to help inform what changes you need to make in order to support your practice. So as you're going through those 8 implementation drivers, you could at the same time be building your action plan, implementation plan, work plan, whatever you'd like to call it, so that you're identifying those changes and you can make those changes within the timeline that you that your project is in the reasonable timeline that your project is slated for. So we've talked about exploration, what we want to implement. We've talked about installation or planning for how you're going to support that implementation and what changes need to be made. And now we actually get to try it all out. So initial implementation is really about activating the who. So that's our first implementers, that's our clinicians trying the new practice, trying your new processes, trying out your plan, and figuring out if it works or if it doesn't, and what needs to be improved. So like I said, here are some key things within this stage. So we're actually delivering the practice now the way we've defined it, and we're starting to assess through our evaluation and collection of information and data on how it's going, and also feedback from the implementers. That's also very important. And then once we've assessed how everything's going, it's now important to figure out, well, do we need to make more changes in order to improve our plan and really refine our practice so that we're seeing the outcomes we want to achieve. So I'm going to focus mainly on the assessment and revision of your processes and look a little bit deeper into how to do that through the use of improvement cycles. So in the initial implementation stage, it's really important that we're learning and that we're trying things out, and if things aren't working, we're trying a different approach. And it's a very awkward stage because you don't really know what's going to happen, and that you may just be through trial and error and problem solving and rapid problem solving, figuring out how to refine your plan and the things you've put into place in order to improve your practice delivery, and also in order to ensure that your clinicians are properly supported. So one of the strategies that NERN talks about is to use the PDSA cycle, the Plan, Do, Study, Act cycle, which is a very common improvement cycle, in order to help achieve those improvements in a more systematic, planful way. So here's the Plan, Do, Study, Act cycle, which probably most of you are familiar with. This enables you to quickly look at the feedback and data and figure out if a change needs to be made. If a change does need to be made, it's important to first plan, well, what question are you trying to answer, figure out how you're going to answer that question or address that issue, and come up with a new strategy that you want to try out. So then the do part is just trying out that new plan, trying out that change, seeing if it's addressing the problem or the issue you've identified, and to collect that information and how you're going to know if that new plan is working. So the study piece is then taking that information you've collected with the new plan and figuring out if it worked or if it didn't. What did you learn? Does that mean you need to make a change or not? Do some analysis on what that feedback is telling you as an implementation team. And finally, decide on whether you're going to act on that change. So act in terms of adopting that change because you saw that it was more successful, or whether you're going to try something different because it didn't work and you're going to repeat the cycle again. So as you notice, it kind of goes around and around and around until you're really figuring out what works for you. And this is all about improvement. It's not about failure. It's about getting better and figuring out different strategies in order to get you there, because it's not going to work. Everything's not going to work the first time. So it's really important to have a systematic strategy as an implementation team to how you can address those changes that you need to make in a more planful way. And through the PDSA cycle, that's one of the approaches that you can use to do that. So once again, for your information, and I'm not going through all these activities, but here are some key activities for your implementation team to complete in the initial implementation stage. So the take-home message is really, this is a learning period, figuring out what works and what doesn't, and using data and your feedback to inform your decision-making. So not going on feelings or hunches, but really being thoughtful in what decisions you're making in order to improve based on the data that you're collecting. And the PDSA cycle is a method in which you can use to do that. So we're moving into the final stage of implementation, and that's full implementation. And in this stage, you've kind of worked out all of the kinks from initial implementation. You've run lots of improvement cycles. The practice is really being used the way you're intended. You're seeing good positive outcomes, and it's kind of this notion as business as usual. It's just how you do things now, and it's becoming more automatic. So in full implementation, your implementation team is still not done with its work. There's still work to be done in this stage because I think so often we think, oh, yay, it's working, and now our job is done. But because our system in healthcare is so complex and ever-changing, it's really important that you continue those strategies and processes that you've used from exploration all the way up to initial implementation to continue to monitor and refine and support that practice on an ongoing basis. You might not be meeting with your implementation team as often. You may be touching down, a couple times a year or something, but you have a way in order to address how the practice is going. So once again, we're focusing on these improvement cycles, and they're not large changes anymore. They're smaller changes that really are just about monitoring and refining and responding to any changes that may be happening out of your control in your clinic environment or your unit or program environment. Because we now have a system to address those changes, so when changes happen that are out of your control, in full implementation, your team now has a way in order to address and respond to those changes so that your practice is still being used the way it's intended and you're still seeing the sustainability and the outcomes coming out in it. And so I've touched on those a little bit here in the list of activities. So ensuring that you have a system in place and processes in place that monitor the practice and continue to support your clinicians and ensuring that their needs are being met, and also ensuring that you have a way to some sort of mechanism to gather that feedback and data on an ongoing basis. So there is open lines of communication to really inform how everything is going. And then when needed, make those changes and make those smaller changes, or maybe you have to go back to exploration, like I was talking about in these stages. You can go move throughout them all, and you may have to go back and do some more literature searching, a more assessment of your new environment or something. But at least you as an implementation team have established the systems to really support any changes that come your way. So if you don't take home anything, take home this. In summary, we really want an effective what or intervention through evidence-based literature with an effective approach. So that's your implementation process that is more systematic and thoughtful and planful, times your context and making sure that this works for you. because where it may work somewhere else, it may not work for you. So how can you really adapt that intervention to make sure that it's going to work within your context? So if you notice, this is a multiplication formula. So if you had an ineffective intervention or an ineffective process or an ineffective way to look at your environment and not really assess it for how it could support implementation, anything times a 0 equals 0 outcomes. So really you need these 3 pieces to align in order to really see the outcomes you want to see and make a difference for our patients and families. So if you're interested in any implementation science resources, specifically from the National Implementation Research Network, I have included their synthesis of the literature as well as their website, and they have a newer active implementation hub that has built-in modules for each of these stages and frameworks that I kind of touched on today, and some key activities or some tools to help go along with them, to help build your implementation capacity. And just a friendly reminder that we have a second webinar coming up next Wednesday, same time, May 20th. And this is where we're going to look at the practical application of this framework. So we're going to provide some fairly detailed examples of how we've achieved some of the activities I touched on today and what supporting tools we use to help us achieve those from those pieces from an implementation science perspective, specifically related to one of the projects we've worked on in ASD diagnosis. And next week will be myself and Cindy Koning delivering that. So if anyone has any questions or more information that happen to pop in your head after we get off this call, then feel free to email any one of us. Thank you.
All right. Well, thank you very much. Certainly a jam-packed, full of information kind of presentation. I mean, there was really a lot of great information there, a lot of great structure. So we don't. Well, this is my chance to remind the audience to type in any questions that you might have. I think that's a great setup for part 2 when we actually see how you put it into practice in an actual program. I think that's really going to bring a lot of this to light and really sort of start the conversation and the discussion and the questions at that time. But yeah, if there's been any questions, please start typing them in. And Gail, if you have any comments or anyone else, please go ahead.
I think from a clinical perspective, just kind of jumping forward to next week, the work that has been involved in the autism spectrum disorder diagnoses was really, it's still ongoing, as Laura mentioned, that you really don't stop. You're keeping, this is an active process continuously, but we had so many drivers for needing to develop a change in practice, including the huge number of requests for assessments from the community with no ability to expand our resources, either in terms of physician resources or the other members of the interdisciplinary team, and yet wanting to be able to provide best practice for the diagnosis and ultimately helping connect our families and children to the community-based resources that they need. So there was lots of tensions and drivers that we needed to do this, and the team will be presenting on that next week. But I think to have everybody reflect on their own clinical practice, where we may have been doing things just the same old way for 20 years, that with all of these different drivers in change in who needs to be assessed and provided with interventions, the real funding barriers that are being put in place in healthcare, I think all of the people on the call could probably just, with that bit of reflection, identify areas within their own organizations or even community services. We're talking about a hospital-based rehabilitation center, but almost all of our work in pediatrics at the Glenelg Rehabilitation Hospital is community ambulatory and partnerships with community organizations. We only have a 10-bed inpatient unit for pediatrics. So I think even community organizations can reflect, use this process to see, with new drivers, what do we need to change?
And one of the questions I have is, this is a great sort of process, start to finish, very structured, broken down into the different pieces of developing the intervention and getting the agreement on the intervention and making it clear and the buy-in, having that leadership piece, et cetera. I always wonder if, it always seems like every single piece of the process is critical, and if one of those pieces is missing, then the whole thing just sort of starts to fall apart. So if you have all of the pieces about the intervention and the research and the frontline clinicians are bought in, but you don't have that leadership buy-in, for example, then the whole thing sort of just stalls there. Is that really the way, is that sort of a good assessment of it, where you really have to focus on making sure every single piece is in place, or are there ways to get around some of those pieces if they're not there?
Well, I just kind of flipped to that implementation driver slide because we might not be strong in all of these areas. And the way that this kind of works is that strength in one can compensate for strength in the other. And that may just be due to lack of control that you have in one of these areas, but they really support one another to achieve your outcome. Oh, sorry, strength in one and weakness in another. Sorry, Leslie just pointed out my little slip there. So if you're weak in one, your strength in another can really compensate and then be integrated in order to still achieve your outcome. So I found that with some of our implementation teams, for example, selection has been difficult for us to address, as well as some of the systems intervention things, so some of the cultural things or the way that we've done things for a long period of time. Those are huge challenges for us and sometimes completely out of our control. So we've really focused a lot on training and coaching and leadership to compensate for some of those areas. Mm-hmm. So it all doesn't fall down.
Right. No, that's great to know. Yeah, and that's a great way to put it. That you can compensate for some of those pieces through strength in other areas. No, that's great.
Not to say it isn't challenging.
Yeah.
Or doesn't take a lot of work, but you really do need to identify your gaps in these 8 areas and if and how they could be addressed, and if they can't, where could you really strengthen your other area in order to still move the work forward. Because one of the main messages I've always heard from the NERN group that I luckily have some really good ties with is that you just have to get started and get better. Mm-hmm. You just have to do what you can to improve and get better. And we do live in a crazy environment, like Leslie mentioned earlier. It's very complex, and sometimes you can only do what you can do. But this at least provides an approach for you to touch on as many of these different areas and achieve as many of these activities that you can. So at least you're going through a systematic process to be as successful as possible.
All right.
Just another comment about the importance of teams as opposed to just a single person being a champion of a new idea. They've been to a conference, they've heard this presentation, and it really would be quite applicable to our business. That person comes back as a single champion, but a single person cannot make change. So the importance of, and we're very fortunate here at the Glenrose to have leadership that works on team-based activities right from the point of the basic assessment to the how we do our day-to-day business. So being a member of a team is really great, because trying to be a single champion is very frustrating.
All right. Well, we are just about out of time, so maybe we'll just wrap this one up here and maybe get some comments from our panel, and also welcome comments from Gail, to sort of maybe close this one off and set us up for the next session just before we sign off.
It's Gail making the first comment. I think the good clinical examples next week will give the audience, the can use the clinical examples in their own practice. So I think this will become more real. We've got the theoretical framework established today. We've got the language. We've got common ground to start from. But how we've been able to apply it to specific clinical questions and make significant improvements, I think will be illustrated next week. And moving forward, we're actually, to tie this in with the work of CAFC, and CAFC has been doing a lot of work within the community practice on transition. We've also been doing work here at the Glenrose on transitions of youth with complex needs into the adult system of care. And we are approaching our transition work using this framework. So we're just going to be rolling that out over the next several months.
This is Laura. My final comment would be that this is a lot of information, but it's actually nothing. I don't think it would be everything brand new. The terminology might be a little new, how it's packaged might be a little new, but this is all very practical ways to implement, just put in a more systematic way. So please don't be deterred or overwhelmed by the amount of information. I think next week, like Gail kind of said, will really help solidify kind of what that looks like, what some of these activities look like when you do them with your implementation team, and I think that will better help reinforce some of the things I talked about today. But that has just been a reaction from many teams when I first implement, is that this is new language and it's a lot of information and I don't want to miss any steps, but the important part is to really just think about what does make sense to you and think about how it can be applied within your setting.
And it's Leslie, I would just echo that. I think this will become more concrete next week with a specific example. And if anyone has any questions or comments, as Laura said, please don't hesitate to contact us. And thank you for the opportunity to present today.
Thank you.
All right. And this will also be my opportunity to apologize to Leslie for messing up the introductions, because if I did give her a proper introduction, in addition to her being the clinical outcomes site lead at the Glenrose Rehab Hospital, I would have also acknowledged all of the work that she does for the PERS, the Pediatric Rehabilitation Reporting System, that she's been a big part of for a number of years, starting as the national data set work with CINSER, but now transitioning over to the Canadian Pediatric Decision Support Network. So certainly my apologies for not getting that straight here. And
that's okay, Doug. Don't worry.
All right, and with that, we'll sign this off. So thanks for a great presentation, as we certainly acknowledge, jam-packed with information, and really looking forward to hearing how this all plays out in the clinical setting next week with some great examples of how this is all put into practice. So thanks again to our presenters and to our audience. We do our webinars every Wednesday at 11 a.m. Eastern, and it's always great when you can watch live, as you get the opportunity to ask your questions and provide your comments. But if you can't watch live, as I mentioned at the beginning, we do record these sessions and make them available after the fact on the CAN, along with any documents, links, or anything else that PowerPoint slides, etc., that our presenters provide to us. We put all of that information up on the CAN. For the next couple of weeks, we have a great lineup. As we know, part 2 of this session on implementation science will be next week, and then following that on May 27th, we'll have the first episode of a 3-part series on patient safety. The first part titled Patient Safety After 15 Years, Disappointments, Successes, and What's on the Horizon, and we'll be bringing Dr. Trey Coffey and Dr. Kaveh Shojanya, where they will give us a sense of what the patient safety movement has accomplished since it started about 15 years ago, where the focus is now, and maybe give us a little bit of a sense of what we've done right and maybe where we've sort of not, some of the things we haven't really accomplished that we thought we might accomplish when we started the patient safety movement all that time ago. The second part will focus on how design can influence patient safety, and for that we'll be talking about designing the physical environment, medical devices, even how we design our information, and how all of this can affect the safety of our patients. And for that session we'll be bringing Wayne Ho from Health Human Factors and Kim Streitenberger from ISMP Canada. That ISMP is the Institute for Safe Medication Practices. Again, that's a part of a 3-part series. The third part will be in September, still to be determined the exact topic, but should be great. And this is a three-part series that we've been able to produce thanks to support of our colleagues at Mallinckrodt Pharmaceuticals. They've sponsored that series. And then on June 3rd, we'll have a session called Physical Disabilities and Obesity in Children, Clinical Dilemmas and Research Priorities, and we'll be talking about issues related to the childhood obesity, which we're all familiar with, but putting it in the context of children with disabilities and how those the issues of obesity are uniquely affect children with disabilities. And for that session, we'll be welcoming Amy McPherson and Julia Lyons from the Holland Bloorview Rehabilitation Hospital in Toronto. So some great stuff coming up in the next few weeks, and thanks for joining us today, and hopefully we'll see you back here next week. Bye, everyone.